Can't have an AI discussion without talking about ethics and governance related to AI implementation of technologies. Janae is going to be having a conversation with Dr. Chris Gibbons, the founder and CEO of the Greystone Group. So they're going to bring it home as we get down to the bottom of the hour, and I look forward to this conversation.
I'm really looking forward to it too, because I love speaking with you every time, Dr. Gibbons. The digital health revolution, it promises to transform healthcare delivery, what's going on in technology. And it also raises ethical questions about equity, access, recent developments in tech regulation, such as the FTC's huge antitrust ruling against Google. They highlight this complicated landscape, and I'm honored to be able to talk to you. You're an expert in this space. For those of you in the audience, Chris has served on the Health Innovation Advisor for the FCC's Connect to Health Task Force, working to ensure that broadband connectivity is increasingly recognized as a vital component of healthcare infrastructure. And his work centers on critical issues of bias, equity, access, and quality. And we've been able to speak before about risks in AI algorithms, training with limited data sets, and I want to talk today about that goal to harness AI's potential to improve healthcare for patients and providers while we're ensuring safety and quality. So I'd love if you could introduce yourself to the audience, and then we can go right to it.
Sure. Thanks, Janae. It's good to be with you again. Always enjoy talking with you as well. Good afternoon, everybody. I'm Chris Gibbons. As Janae said, I'm a physician by training. I trained in surgery and preventive medicine, and I was on the faculty at Johns Hopkins for many years, and also the associate director of the Johns Hopkins Urban Health Institute for almost 15 years. And since that time, I started a digital health and innovation and healthcare transformation firm about 15 years ago and have been doing that full time now. My interest in the area started as a junior doctor more than 20 years ago at Johns Hopkins, and I heard about this thing called e-health, and I had never heard about that before in medical school or anywhere else. And when I learned about it, I said, yeah, that's going to be part of my future. And so I've put together looking at technologies and health outcomes and underserved populations.
Perfect. All right, let's talk about that. How can we ensure that AI applications don't perpetuate or exacerbate existing biases? But maybe we should start a little earlier than that, actually, and say, why are they there? Like, we've heard stuff like, this AI thing can't detect my skin cancer in darker skins, but where did that come from, these biases?
I think, just a little level set. It's important. A couple of our other presenters brought it up. Nick brought it up. Others brought it up. We talk about AI as if it's one thing, but it isn't actually. There are many different kinds of AI, and they can be, bucketed into two main groups: the sort of rule-based AI that's pre-machine learning, and then really the generative AI, which is based on machine learning and others. And the reason that distinction is so important is for issues like this, because some of the problems and the solutions that you might suggest for rules-based AI will just simply not work for generative AI. And if you don't understand that, you could be putting in place at your hospital or your system solutions that you think are helping to improve some of these problems. And in actuality, it won't do anything at all. It's a much harder problem, a much more complex problem in the generative AI and the large language model space, for which there are not a lot of good answers. But let me just say this. A lot of people have also talked about the data set problem, and that is a problem. But I have never seen a perfect database.
No.
I don't know that exists. So, trying to say that a solution for rule-based AI or for generative AI is to fix the data set, I mean, that's a non-answer. There is no such thing, right? So and then beyond that, in the generative AI, let's say for a moment, you could fix the data set problem. You could actually fix the bias in the data set problem and still not fix the bias in AI problem, because there are many other sources of where bias can enter an algorithm. The data set is just one.
Ooh, I really like that you could fix the bias problem in the data set, but you still might have a problem. Let's go into that a little bit. Like
Sure.
how do they identify the problems or issues, and how do they mitigate them?
Great question. It's an area of a lot of activity now, a lot of work. But also, I would say this is an area that you should take seriously, right? Because the more work that we do in it, we find the more complex it really is and the more difficult it is to ameliorate it. But let me just talk about a few, not all of the what I say threats to equity or challenges that may lead to bias. We know of some already. Have heard them today. Hallucinations. Those are frequent problems, particularly with large language models. Some estimates are very high in terms of how often that happens. It tends to happen on questions and problems that have less data available. And guess what? There's less data in general and in many specific instances when you're dealing with healthcare questions around many underserved populations. So it shouldn't be surprising that it might be more likely to be seen in those when dealing with those populations. However, if you can't tell that that's what it is, we've got a real problem. But let me go to one. We also heard about model degradation and model drift. This idea that once you have an AI model, you cannot just believe that it will be great forever. The mod like a car, it goes bad over time, and sometimes it can go bad pretty quickly. And the only way that you'll know that is if you test for it, and then do what needs to happen to fix that problem. So that's another area. But let me talk about one that most people haven't thought about. These large language models, and it gets complicated. I'm not going to get into how they actually work, but they're also known or can be known as hyperdimensional systems. And what does that mean? Well, our human brain can handle thinking about, we can think of, a person is a male or a female. They are rich or poor. They live in an urban area or a rural area. They're black or they're white. At any one given time, we can handle, who knows, maybe 10, 15, maybe 20 at the most dimensions to think about when we're talking about something. They have insurance, they don't have insurance, right? But these generative AI models and systems, they're hyperdimensional, meaning they can look across a data set across 1,000 or 10,000 parameters to then see patterns. That's what they're designed to do. And this is a perfect example. So these ideas of de-identification or traditional masking that we have used in statistics for a long time to try to protect people's privacy and protect the data, or even in rule-based AI, they simply won't work in generative AI data sets, because you block the one or two or three or five variables that you think are PHI. The system still has the ability to look across 10,000 other parameters and detect, oh, this is a person of this kind or that kind or the other. And we see this even in radiographs or images. This is not just text-based. It's phenomenal how these things can work. So it's very tough, very, very, very important issue.
Yeah, I think that it reminds me of when people say you can't really de-identify your DNA. Like there's going to be a way around it.
That's right. That's right. So,
Let's
you want me to comment on what do you do about it? I forgot to.
Yeah, and we're ready. How do we address the bias for socioeconomic status, race, or gender driven? Like how do we do it? How do we fix it?
You know,
2 seconds. That's all you need. Just kidding.
yeah, that's right. Let's just do it. I mean, first of all, is to take it seriously and not ignore it. You know, it is real, and do you got to start somewhere, right? Um, but then there are things that we can do. I mean, there are people looking at small language models. The other thing about the large language models, they're largely, in many cases, unexplainable, right? We don't know exactly how they got to the answer, right? That's a particular problem. And you know, if that's the case, how are you going to fix it? Looking at small language models, or putting small language models on top of large language models for specific populations, is one way that some are trying to deal with this problem. Google has come out with some ideas around adding policy layers to the models as one way, as another way of looking at this. And what that is basically, after the model works, prior to it spitting out an answer, it goes through another policy layer that says, okay, is this answer going to go against some policy that just wouldn't look, this wouldn't look good, or this isn't right? And if it doesn't, then it'll spit out the answer. If it is, it'll at least block. It doesn't fix the problem, but at least it can help in stopping the model from putting out fraudulent answers or recommendations. These are some of the ways that people are using to try to deal with this bias problem, in addition to improving the data set issues. But there are no foolproof solutions yet.
Right. So you build in the check in addition to having humans check.
One way. Well, even
We
on
have
that humans check part, I'll just say this. Remember, we have to keep everything in context. Before we had AI, we had humans and we had bias.
right.
So the human doesn't make it perfect, but we need
Right.
humans.
Yes, it has to work together. There is an audience question I think relates to what you were talking about earlier. They asked, what recommendations do you have for healthcare organizations in regards to data governance to prepare for the use of AI in the clinical setting?
I think this is a good question. This is I think this issue, as well as several others, ought to be part of your data government strategy. I mean, many of the times, people talk about trustworthiness, they talk about safety, they talk about these kinds of things in a governance strategy, and those things are important. But again, I keep it in context. We've had the Flexner report in healthcare, and we've been talking about ethics, we've been talking about trustworthiness, but we still have bias. So from my personal viewpoint, those things alone are not enough. They are necessary, but not sufficient, as we say in healthcare. We have to be explicitly focused on this at a governance level, in thinking about it, when we're thinking about purchasing, building, developing AI tools, and how to mitigate them. We could talk about that a little bit more if you want to.
We could. I want to also make sure we get to some of these other questions.
Yeah, sure.
And I think we need to talk about the FCC and Google as well.
Sure,
So I'm going to
sure.
combine that question with a question from Peter Kaplan. How do you see medical malpractice and liability insurance being
Yeah,
impacted
yeah.
by AI? Depends on the state. Some states, disaster. Some,
Yep,
nothing will
yep.
happen. So, but then let's talk more about that regulatory landscape. Like, what's going on here?
No, I think this is another big issue. I've had several conversations now with lawyers at several DC firms and things just about this issue. And while we're at the beginning of the curve, obviously, and legislation is being written as we're talking, and the landscape is changing, generally, my question to them is, how are they thinking about this, particularly, not only, but at least in the area of bias and outcomes? I mean, we all know the Optum algorithm problem now. That's the subject of huge lawsuits. Which is exactly this issue. An AI algorithm used for clinical decision support was giving wrong information and making wrong recommendations about African American patients, maybe as much as 40 to 50% of the time. But at the same time, making rights recommendations for other populations, right? So
Mhm.
we already have examples of this. This is not something that might happen one day. And there are plenty of examples. That's just one of the best known ones. So I would ask them, what does this, what kinds of implications does this have for hospital systems, for providers in the future in terms of liability risk? Whose liability is it? Is it the software development company? Is it the hospital liability? Is it the providers who are actually relying and using the system? And it's nebulous now, but the way I think about it, and the way I discussed with some of them is like, look, again, I think we have to start from what we know and start from where we were in the world before AI. We had all of these problems, right? If you had a IND, an investigational new drug, and if it can be shown that the company developing the drug didn't develop it to the standards that they should have been developed, then they're going to hold some liability. But if it can be shown that the provider used the drug inappropriately and didn't provide the standard of care, then the provider is going to hold some liability. If the hospital system bought it in some way that wasn't appropriate, they're going to have liability. And at least for starters, that's how I think it will play out in the AI world too. So that means a hospital system, and they're thinking about these things before they buy. They need to ask. There's what are the bias implications? What populations have this been studied on? What has it not been studied on? What are the target populations you're recommending that we use this on? And where's the data? Don't just take their word for it. Ask to see the data, because that's the problem we're having. There's so much hype about what AI can do, and it's really not producing at the levels that we are. And if you've done, the bottom line in terms of legal liability is, if you as a hospital system, this is a question I asked them and they agreed, or they answered in this way. If you're in the situation where you're employing AI and it has shown bias and it has caused some problems, you're in one legal risk category if you have not done all that you could do to understand that risk and mitigate that risk. If you have done all that you could have done, all that has been recommended to do, and it still happened, it's still bad, but you're in an entirely different legal risk category, and that's where you want to be. So ignoring this because you don't believe in it or you don't think it's important does yourself no favors at all.
Right. Yeah, you just can't pretend that it doesn't exist.
Right.
We have another question. It's from Sharon. It says, I'm a clinical quality measure developer for federal programs, including value-based care models. How can AI be used to understand population needs to develop mutually beneficial risk-sharing calculations?
It's a good question. Again, I just think we have to be careful, right? Because we're all, and we should, right? We're still in the exploratory phase, as others, even Chris Ross in the beginning from Mayo is saying, they're exploring it in many different areas and seeing efficacy in some of those areas, administrative efforts, some in clinical decision support and radiology in particular. Um, there's been no large scale implementations across the nation that have been both effective and cost effective and bringing in new revenue. All right. Because they're very, very expensive. And so we have a situation where often running down the road of how can we use it to do this, but yet the systems still have issues that have not been worked out. And my suggestion is, particularly in the generative AI realm, again, it's a little different. The systems are a bit more worked out. We have more experience. We know what they can and can't do. We know how they can and can't do things generally in the rules-based AI. But in generative AI, large language models, it's the wild, wild west. And using these tools to run down to do this or that, when we already know you can't always trust the outputs that you get from this, to me, is putting the cart ahead of the horse. And again, not a wise choice outside of experimentation, outside of a pilot study or trial to see what the experience is in your environment.
Right. Don't put the cart before the horse. So I hope that, let me see if we have other questions. Not yet. So I think that's critical. I want to talk a little bit about ethical standards, but also let's talk about some success stories. So pick which one you want to start with.
Well, we can talk with some success stories. I mean, there are I don't mean to imply that we should never use even generative AI or rules-based AI, or it cannot be used positively. We've already heard some examples today of that, where at small scales and others, that it's being used. I think there are a couple of tools out there right now that, again, in I'm not going to talk about radiology. I'm not going to talk about clinical decision making. Nick and others, and Chris Ross and others have talked about this, so I'm not going to rehash that. So I'll talk about in the area, one of the areas that we focus on in the sort of bias and equity space. There are tools out there now that have been developed that are AI based, that are helping this problem. One is a platform called Healthify. It used to be called Healthify. They changed their name to WellSky.
Okay.
WellSky. And I know this one particularly because this was started actually by a group of Johns Hopkins students many years ago, and they came to my office to ask me to what I thought about it and give them some advising. But these were undergrad students at the time, and they were volunteering in the hospital ED. And as happens in many hospital EDs, the paying patients were able to receive a certain set of services, and self-pay patients received a different set of services. We'll just put it that way. And students being the what's the right word? They want to fix the world, kind of. They say we got to do this better. We can't just give our self-pay and Medicaid patients a referral on a piece of paper and hope that it happens. And some of them had some software development skills and started a service, and now today it's a company that's national and doing very, very well. But basically, they are a social care coordination service. One of the major problems hospital systems have, the providers have, is if they have a patient in front of them from a population like this, and they have more social needs than they do healthcare needs. I've in the past, I'd say, oh, it's not a medical problem, we can't help you. And in some cases they can't do that, but they don't know who to refer that patient to in the community that can help them with that problem, because they're largely focused in the hospital. They don't have any knowledge or very little knowledge of what's happening in the community. This platform helps connect community validated, high quality, community based resources for social services beyond the government with providers in an easy online format, and then follows up with the patients and helps with care management. That's a good system that's out there now. Alvi is another one. Similar AI-driven social determinants of health data management system, in some ways similar, but doing some of that. Those are two examples, I think, of systems that are using AI in a positive way that help these issues, and have managed to handle the problems that come with it. They're probably both rule-based AI rather than generative, although I know Healthify is exploring generative AI capacities on the provider side.
That's fascinating. Just hearing about things that are working and how they want more data sets, talking about bringing in social determinants of health data. What role do these different teams have in like implementation, compliance? Like, do you know health systems that it's working great with community care? You mentioned that care can be different depending on your background.
Yeah.
What do you see any factors that are common across successful interdisciplinary teams?
Yeah. I mean, look, there have been and continue to be in so many cases challenges between the ivory tower, the big hospital, and the community. Particularly large academic medical centers in this country are often located in urban ghettos. Let's face it, it is what it is, but not always. And those relationships have been fraught in many communities, not just mine where I worked, but others. And so they have to work to overcome that, right? That's sort of a starting point. And different places are at different places. But then those that have been able to or are being successful generally have taken much more of a collaborative approach. It's not the experts telling you people what to do. It is one group of people saying, hey, we know something, but you're the experts about you. Let's work together in your community. Let's work together to make this better for all of us. And that work is not easy. It takes time. Interestingly, I believe technology has a role to play to helping us scale that kind of work and do that kind of work in a way in which it was not possible years ago. It's very human labor intensive, but technology could help us to do that in a very different way. But those hospital systems and organizations that have taken this approach and invested the time and resources are being successful in making progress along these lines.
That's nice. It builds into my dream of having AI finally make an appointment for my kids that I don't have to make. Like,
Absolutely.
that's the dream, right?
Yeah.
Like having
Well,
something that's
yeah,
coordinated in our communities based on
absolutely.
what we really need.
Right.
Um,
It's not, it will come.
it will, you know what? That's the best news I've heard all day. We have another question.
Sure.
Um, how do you see the role of robotics evolving with how it interacts with
Yeah, I think
AI?
that's absolutely a part of this. There's a lot of tremendous again, there's a lot of hype with robotics, but there's also a lot of good potential and real applications. But it's interesting. If you had to guess, if I could have asked the audience if they could respond, they could respond, they won't. But today, as of today, and this is actually old data, but how many robots do you think are in use in America today? What would you say, Janae?
I wouldn't guess. I would evade this question.
No, no, just guess.
Should I
Just
Google? I have
guess.
no idea.
Do you think
Depends on
it's
the
like
type of robot. I think it's huge.
how huge? You're talking a million or something, or half a million? Any kind of robot doesn't
Probably
matter.
more than that.
More 10 million?
I have no idea. I'm
Yeah,
not going
good.
to give you a number,
Okay. Okay.
but I will
So
tell you that my friend helped make Cheetah
is that
related to
right?
Big Dog. Yeah.
Yeah.
So
Well, the biggest
I wish I could
application,
text him right now, ask him, be like, how many robots? Because he'll know.
right? The largest one of the largest applications of robots in this country is not in the healthcare space at the moment. It's outside the healthcare space. And the minute I tell you, you're going to know it. It's the vacuum cleaner, Roomba. They've sold over 30 million of those, right? So we tend to see robots as these, I'm dating myself now, these lost in space kinds of things. The young kids don't have any clue what I'm talking about. But they're not. The robots, can it be everything from chatbots, as we've talked about a bit today, which have no hardware, they're software bots, to vacuum cleaners and others. So the potential that I say all that to say the potential for robotics, I think, and I trained as a surgeon, so I understand the surgical implications of robotics, which are happening now, and remote surgeries, which are beginning to happen. One of the things that is holding that back more than anything else, especially for delicate surgeries, is really not the robotics itself per se or the surgeon, but it's the networks, the broadband networks, and the latency that we have. The latency is just too high, particularly for very delicate surgeries to do that. But it's coming down. It's coming down precipitously. So the day will come where more of that will happen.
That's good, because the computing power to run these is huge. And
Right.
when we talk about that, and the environmental impact until we get to better latency is staggering.
Yeah, yeah, it
Let's
is.
let's talk about another question. Is there
Yep.
any confirmation when you put data info PII into an AI or LLM that the information will be stored and will then be used and considered as data breach?
I'm not sure I understand the question. What could you
I'm
just
not
repeat it?
sure. It looks like they want to know about data storage within language models.
Large
And
language model.
yeah,
Okay, so
like is that going to are we making them more vulnerable through
yeah.
use?
Well, even that question is not as straightforward as the asker might imagine, because data can and is stored in a variety of different ways across a variety of different institutions. It's not as though all data in all AI systems is going to one place in a what we used to call old data warehouse or new data lake. That's one way data can be stored, and some institutions do it. But now, increasingly, as we go towards AI and generative AI, as I think is implied by that question, those become potentially huge security risk, right? Because if all your data is in one place, all it takes is for somebody to get into that one place and they got all your data. So how do you mitigate against that? And, make it harder for them to get in. Yes, that's one way. But another way is storing data in different places intentionally so that nobody has all the data and nobody has enough data to put it together in order to use it in a nefarious fashion. That's another way. Another way is storing it in multiple places, encrypting all the data, and encrypting how the AI works, so that the AI is actually never working on non-encrypted data. Right? It is doing its calculations on encrypted data in an encrypted environment, and the results are generated and given encrypted, and only the people, the patients, the provider that have the appropriate key can encrypt that data and therefore know what it's actually saying. These are different ways of handling that problem that are being tested and being used. But the idea of storage is, again, not one thing. There are several different ways and different things to think about.
We had a follow-up question to that one. It says, does the actual use of putting data into the LLM, is it considered a breach of privacy for the people involved?
Putting it into the LLM. So the I
I'm
think what
guessing,
you're trying to
yeah.
get at is the answer is no per se, but I think it's part of a broader question, right? So the way these large language models work is that they're made. You generate a model, and you have to train the model, right? That means just like a child needs to be educated about X, Y, and Z in order to do things. These models need to be educated. And generally speaking, whether it's computer vision, whether it's text to text to speech, anything, large language models are big pattern recognition devices, right? So they can recognize patterns and then make inferences, decisions, calculations about the patterns that they see, as a high level nutshell. And so the training process is using examples, and there are multiple ways to do it, to help the models understand the patterns that you want them to recognize. Now, that pattern could be, this is a cat. The cat looks like this. So the model has to look at 10 million pictures of cats, so that after a while it can then look at another image and say, oh, that's a cat or it's not a cat. All right. they're trained, right? And they can be trained various ways. And then once trained, you then subject it to other data that it wasn't trained on for then it to do its calculations and manipulations. So the idea of sort of loading it into the model. I'm not sure exactly what you mean by that, but that's how they work. And just doing that by itself per se is not a data breach. Now, the final thing I'll say about that, where I think there is a lot of angst, a lot of issues, a lot of litigation even happening right now, is the fact that these large language models need so much data to be trained on. And the ideal is that the more data they're trained on, the more powerful these models can be. And the hope was the more accurate that they can be. And in some cases, that's the case, but we still have hallucinations. We have these other problems. And so what a number of these large companies have done is basically said, use the entire internet to train their large language models. That includes books that are written by authors that and information from YouTube videos that you and anybody else puts on it. And now the New York Times, large news outlets are suing these large language model companies because they're saying, wait, you're using my proprietary information to train your models and then hoping and making millions of dollars off it, and I get nothing. And that's not fair, it's not right. And so that's the world we're living in where that can happen. I actually tested this out several months ago to see how deep this goes. I've written obviously many manuscripts that have been published in the scientific literature. I also have a few books. And so I won't tell you which ones, I actually did it on the three major ones, all three, to see if there were differences, and asked them to give a summary of one of my books. And it was amazing what happened. One of them couldn't do it at all, just said, we don't have this information. Another one gave an amazing summary, an absolutely amazing summary of the book, something I would have said, but because I wrote the book and I know what's in the book, I didn't say that. It hallucinated right in my face about my own book.
In your own voice.
In my own voice. It really did. I was like, I should have said that, right? And
Yeah.
then the other one, the final one, actually gave me two summaries and asked me which one I like better. It was amazing. So these are real issues that have real practical implications. I know the difference because I wrote the book. Imagine if you're a provider asking this about a patient on a problem and you don't know the book, you don't know it, and it tells you something, and you take it as being, the truth, and it really isn't.
Right. It's like a recalcitrant child giving you an answer that sounds like you, and the face looks a little bit the same, but it's not quite the same.
Right.
We did have more follow-up from the audience about like putting the data in, and also said the person whose data is being shared, or how do they provide notice or consent to sharing data? Like, let's say I'm going to the health system. Did I consent when I went to that health system to share with Google? Like, when did I sign that form?
Well, that's the whole point. That's why they have these lawsuits. And I've been thinking about that in the context of equity and all of these issues. New York Times can sue Google. Pick your big company. Mayo Clinic can sue Google. But Joe Johnson living on Main Street can't sue Google, right?
Right.
So
then it becomes a class action lawsuit, and we know who makes money in those, the attorneys.
So and that's right. And so where is the equity? Where's the fairness? Why should average Main Street America or minority or underserved population trust these systems, which have been trained on stolen data from them and everybody else? You see, the implications of these things could get significant.
Right.
But it's a good point that the asker is bringing up. There hasn't been authorization. You didn't give anybody the ability to do that, or the authorization to do that. And why should everybody else make money off of your data except you?
Right. Why would everybody else be able to show you the ads and be able to make money of it?
Yeah.
All right. There are a few more questions. I really like what you're saying about data privacy. Follow-up question for me, can they trust it?
Well, again, this I think the devil is in the details. It depends on what we're talking about. If we're talking about rules-based I think generally speaking, we have much more of an ability to trust it because we have much more experience with it. We understand it a lot better, and we have a history with it. When it comes to generative AI, which is the raging thing now, I mean, you heard Chris Ross say at the top of the day today, it's there for some things, but it isn't there for a clinical diagnosing things without a clinician. It's not there yet in many applications. And going beyond that, um, there are reports coming out of Forbes and everywhere else that no matter what people are saying about it, investors are starting to get upset because it's not making any real money yet. People have to spend a lot of money to purchase it, and it
Right.
costs a lot of money to use it.
I mean,
But
people are making money, the people who build
who are
computers.
selling it. That's right. They're making a lot of money. But the people who are actually using it, even when they see benefit, have that benefit has not been of the such that they can monetize it and then see significant revenue because of that. So the cost effectiveness, the return on investment has not been seen of generative AI, has generally not been seen yet at a level that investors would like to see. So again, I just advocate very strongly that recognize there's a huge amount of hype here, and
Mhm.
and think much more carefully, and we could talk about that. But yeah.
Yeah. So we do have a lot of hype and people get excited, but the people in venture capital are pretty good at making people excited about the potential. And frankly, technology has transformed our lives.
That's right.
There
That's
have been
right.
times when it was the right move to get in, you
That's
know?
right. And
Um,
because of that, we have the FOMO problem,
right,
right? FOMO, fear of missing out. So much in healthcare that drove EHR adoption even before high tech and the money from the government. But here in AI, is not so much that folk are convinced that it's a good value proposition for my hospital, but our competitors are doing it, and I don't want to be left behind like the one that doesn't have. And then just like EHRs, in the first few years of being HRs, one fourth to one third of people who had bought his systems who had bought EHR changed them again because the ones they bought were not right for them, and up to half of them
right,
wanted to change them but couldn't change them. We're seeing the same thing now. This fear of being left behind, fear of being missed out, is driving AI decisions far more than value.
right. We want to be just as good as the people next to us. Final question, and then I want to hear from you. They asked about how to control the biases in training. And then I had, I want to hear what you're most worried about and also what you're most hopeful about in the future.
Yeah, sure. So again, the biases in training, very difficult to handle them and get rid of them entirely. I'm actually even seeing reports that some people believing generative AI cannot stop. You cannot fully get rid of biases in generative AI for a number of reasons. One of which, it's built in a way to do things that are positive that sometimes result in bias. So if you take away
Mhm.
that capability, generative AI isn't sexy anymore. Nobody will want to buy it, right? Um, and so, and I'm
Then it just
actually
becomes Excel, only fancy.
Exactly. Seriously. And I'm even seeing a few reports now where just recently where people are saying we've got to look beyond generative AI. That is not because of these problems, and we haven't even spent time talking about its lack of transparency, its unexplainability because of the deep neural networks. And because of that, we've got to look beyond it. We've got to figure out the next big thing because this can't be fixed. So how do you fix it? Work hard, do and from a risk standpoint, both for the populations you serve and from legal risk, take it seriously, ask for the data from the vendors, do everything that you can do that is being suggested to do. And again, that is, I said to them earlier, don't just take the word of the vendor. Give me the data that shows that this tool has been tested in whatever your target populations are that might be more subject to this kind of thing. Show me where I want to see safety, I want to see efficacy data in these populations, and then safety and efficacy data in the general population or in the white population, and compare it. You can do it yourself. If they're not willing to give you that data, I'm saying you shouldn't buy that system, but at least start there. Do all that you can to put in place oversight, governance oversight. One thing I've thought about is, we have in the hospital systems, we have everything from IRB review. We have M&M Morbidity and Mortality Weekly, where we get together weekly to discuss bad cases or bad outcomes to find out ways that we can improve it. Maybe we should start thinking about doing those things weekly to review the AI and how it's performing in our hospital systems. The point is, even if those things don't take all the bias away entirely, and you still have a bad outcome, you're in a much better legal position if you've done all you can than if you haven't.
I like that. So what are you most hopeful about as we wrap up?
You might be tempted to think that I'm anti-AI, I'm anti-technology. And that would actually be the farthest thing from the truth. My whole career, from a young doctor at Johns Hopkins to now the CEO of this advisory firm, is built on the potential and the promise of technologies beyond an EMR, including beyond telemedicine, including that, and AI and beyond. And in addition, the promise of those technologies, not just for some people, but for everybody. So that's my whole career has been built on that. So I'm very focused. I just think we do ourselves no favors when we ignore some problems as if they don't exist, or if we make it the price of business. Some people got to suffer so that others can benefit. I refuse and reject that. So I'm very excited about the possibilities that are before us, because I think the true opportunity is not just to layer on some technology in the healthcare space on top of what we already do. I mean, that's exciting. It'll help us be more efficient. It'll get rid of waste and redundancies. That's all great. But in my view, the true opportunity, the true potential is to help us to do some things that were previously impossible and not even thought of before, because we just couldn't do it. And not just for the sake of being different, but that are better in
Right.
many different ways. So that's what I would say. I'm most excited about that.
Well, thank you. I like that. The true potential here is that we'll be able to create a world that we couldn't even imagine, like how much it opens up for us. I want to thank you for coming, Dr. Gibbons, and thank everyone. And I love closing on that note that we have the potential here to do things that we don't even know are possible now. And that's super hopeful. So thank you so much.
Our
Thank
pleasure.
you so much, Dr. Gibbons. And Janae, of course, thank you so much. Appreciate that. What a way to close it out. Fabulous session. All right, so I just have 30 seconds to go here. I will be sending all the attendees and registrations links to the video recordings once they're edited and done. And also that Chime link if you're going to apply for some non-Chime CEU credits. We are going to be doing this event again in April of 2025, because, by then, who knows where we'll be with AI, but it'll be someplace different than we are today. I think we all know that. I do want to thank our event sponsors, Inovalon, Avashare, and Atera. Thank you. Without you, we couldn't have done this event, and appreciate your willingness. So thanks to everybody. Have a good day.